Hey guys, it's Duncan here, the hairy old bull physio, and we have our hairless young bull physio, Ollie. We're back this week after you've heard Jackie for the last couple of weeks interview some other specialists in their field, but we're really, really excited today to be interviewing Dr. Stuart MacKenzie. Now, Stuart's an orthopedic surgeon who specializes mostly in knees and hips. And personally, I'm really looking forward to taking away some pearls of wisdom. So I'll hand over quickly to Stuart. Do you want to give us a little quick rundown of why you became a surgeon and kind of what you really love about doing surgery and helping people now?
Yeah, sure. So I decided pretty early on in my time at medical school that I wanted to do surgery because I like the practical aspect of it, the actual operating. It's a very, very practical specialty, obviously. And it's much more concrete in terms of being able to see a direct line from what you do to a positive outcome for a patient. Obviously, all of medicine is very important, but I find the specialties where you're changing people's medications around, although it makes an obvious difference, it's harder both for me and for the patient to see that difference. Whereas if someone comes in with a really badly arthritic hip and they're struggling to walk, and I can do a hip replacement for them, and 6 weeks later they're walking normally and completely pain-free, there's a very clear pathway from problem to solution, and I find that very rewarding.
Yeah, nice. I can definitely see that. I think, I don't know, Ollie, it's probably fairly similar for us as physios as well. It's a very much more practical kind of health profession. So definitely resonate there.
Yeah, I can really relate to the feeling of results, particularly with regards to pain. Somebody comes to you with a lot of pain, it's obviously affecting their life. And if you can turn them around, however long that may take, whether it's one surgery or a course of physio treatment, then it's really rewarding. So,
absolutely, you change people's lives, which is really satisfying.
Yeah, absolutely. In relation to that, where Ollie, you just mentioned either surgery or a course of physio, helping someone get out of pain. This might be actually a really nice segue into what we're going to talk about today, which is the non-operative kind of treatments for arthritis pain in hip and knee joints. So I was talking to a patient of mine the other day in her mid-50s, some hip pain, groin pain, that kind of thing. And she was very skeptical, very scared, firstly, of surgery, which is quite common.
Understandable.
Yeah, it's a big thing. But often, and I think in terms of all surgeries, Stuart, you can obviously add a little bit more here, but in terms of surgeries and surgical outcomes, hip replacements are right up there in terms of the evidence for improving pain and improving outcomes. Is that right?
Yeah, so hip and knee replacements are both extremely good operations for the right person. But hip replacement is probably the most successful operation that's ever been invented, really. So the only other one that competes with it for that title would be the treatment of eyes, some of the surgeries that the eye doctors do. Yeah, hip replacement has been described as being the best operation ever conceived. And in fact, one of the big medical journals, The Lancet, described it as being the operation of the century in their sort of end of 21st century edition. So it's not without potential risks, as any surgery is, but the risks are uncommon. And when it goes well, which it does 99% of the time, it's an absolutely life-changing operation. And many people end up completely pain-free, and as if they've never had a problem with their hip, and day to day they don't think about the fact that they ever had hip arthritis.
Yeah, absolutely. I've seen multiple cases of that, both my grandparents and actually that Lancet article that you just mentioned there. That was the thing ringing in the back of my mind where I had read that about the surgery, the best surgery ever conceived. But obviously patients still have concerns, and like you just mentioned, sometimes surgery isn't the best option, or we can prolong the need for surgery for some point in the future and whatnot. What are some of the things that you would look for if you were not going to offer surgery to someone?
So I couldn't agree more. I think our philosophy should always be to only use surgery when we've exhausted all non-operative treatments that we think might be helpful. Because at the end of the day, any operation has risks, and operations also don't last forever. These days, they tend to last very well, but they can fail and need to be redone. So we wait until people really don't have any other options before we consider surgery. And so you see lots of patients come through. You probably see even more than me. Lots of patients come through who have arthritis and have pain, but aren't at that point where they're ready for surgery yet, and want options for other things that they can use for treatment. And there are lots and lots of different treatments out there. Everyone will tell you different things, and lots of people wanting to sell you things. And some of them work and a lot of them don't. And some of them are dangerous and some of them are just harmless but don't work. So when people come in, and I have the discussion before offering someone surgery, that there are 5 treatments that are evidence-based, proven with good studies, that are good treatments for osteoarthritis, and it's the same for both the hip and the knee. And anything other than those 5 things probably doesn't work. So the 5 things that work in patients who need it: weight loss, keeping moving, active, fit, going physiotherapy is really useful in maintaining, or both in pain relief and maintaining function. So that's definitely important. Avoiding things that hurt. If there are particular movements, particular activities that people are doing regularly that cause them a lot of pain or cause them to have a lot of pain afterwards, try and avoid doing those things. For example, younger patients may be running, and which is a pretty bad form of exercise for patients who've got significant arthritis. They're better off swimming or cycling, or and some certain things people do at work, if they can avoid them or do things different ways, can be helpful. In terms of medication, the only medications that have really been proven to be useful are a group of medications called the non-steroidal anti-inflammatories. That's things like Nurofen, Celebrex, Mobic. Interestingly, lots of people take Panadol Osteo because they're told that they should, but there's pretty good evidence that it's not actually very useful. And that goes for all Panadol and paracetamol. It's not particularly dangerous, so it's a fairly low risk intervention. So if people are taking it and find it helpful, I would encourage them to keep doing so, but I don't usually start people on that. And the 5th one is surgery. So basically, to recap, that before surgery, everyone should have, if they need to lose weight, keep as fit and active as they can, avoid things that are particularly painful for them, and have at least a trial of non-steroidal anti-inflammatories to see if it helps and to see if they're able to tolerate the medications.
Yeah, perfect. I think that rings very, very true. The paracetamol thing's a big one we often talk about as well, and advise the same, that, and that goes for back pain often as well, and other opiates and things. But
such a widespread treatment, and lots of GPs will prescribe it. And as I said, the evidence is not very good for it. And the evidence is actually reasonably good that it's not that helpful, but it's also not a particularly high risk intervention. So if people are doing it, it's not the end of the world.
Yeah, absolutely. And that's something that's worth perhaps considering, is the placebo effect and that kind of stuff, if it's not dangerous. But that's a huge topic which we maybe will talk about another day. I know just on relation to medications, Ollie, you've got a question that they're not really medications, but you had a patient, I think last week, the other day perhaps, that had some questions regarding that. Do you want to?
Yeah, I mean, it's very interesting, talking about some of the things that are commonly described as treatments for arthritic pain that don't actually work. And I noticed in some of the material that you gave us prior to this podcast that a few of them included things like turmeric and fish oil, things that people often associated with pain relief or joint health. Do you want to talk a bit more about what your experiences with patients who are on those or have tried those supplements before?
Yeah, so those sort of supplements, again, there's lots of information out there on the internet, people pushing them, people saying that they work, you can buy them in pharmacies. But some of them have been reasonably well studied, some of them haven't been studied very much at all. The common ones which have been reasonably well studied are glucosamine, chondroitin. They're very common ones. And the studies have shown that they're no better than placebo. So again, they're very low risk. although not no risk, people can have life-threatening allergic reactions to glucosamine. But if someone's been taking it for a period of time and they feel like it's working, it's probably pretty low risk for them. But the evidence is that it's probably no better than taking a sugar pill. Turmeric, I actually tried to research this and I could only find one article on it, and that was an article in a journal called something like the Journal of Medical Food, which is sort of an alternative health type of journal, and even they concluded that that doesn't work for joint arthritis. Again, if people are taking it and feel like it's helping them, I don't tell them you have to stop it, because it's a zero risk intervention. So if you want to take it, it makes you feel good, go for your life. And those are the big ones. The fish oils fall in that similar category. There's not much evidence for them one way or the other. What evidence we do have suggests that they probably don't make any more difference than taking a sugar pill, but they're probably harmless.
Definitely. Yeah. I think that resonates with us too. I've had patients come to me and they say they're going to try turmeric and all these weird kind of things and supplementations, and they come back, a few weeks later, and I ask them if anything's changed, and quite often in cases that things haven't changed.
You get a few people who come in and swear by it and think it's fantastic, but it's surprising the number of people I speak to who are taking glucosamine because someone told them to, or taking Panadol because someone told them to, and they've been taking it every day for months. And when you ask them, do you think it makes any difference? They'll say no.
Yeah. They're looking for any kind of answer or any kind of solution to the pain.
Right. And so if you're taking something that's not helping you, feel free to stop.
Yeah, absolutely. And I think that's a big part that the three of us can play with patients as well, is helping them, because they're not trained on necessarily critical thinking and that kind of stuff like doctors are, and even to a degree physios are, is then maybe helping them guide, well, hey, you can save some money here and not worry about purchasing all of that, even though it's not harmful.
But that is, if they feel like it is helping them, feel free to keep taking it as well.
Yeah, 100% resonates with me particularly well. Let's talk maybe about some of the treatments that do have some risk that are non-operative, because I had a patient probably, I don't know, maybe it was like 3 months ago. Her name was Mary, and she'd read somewhere about stem cell therapy for her hip OA, and I was actually trying to refer her to you, but I don't know if she ever came to saw you or not, but she went to someone in Sydney about the stem cell, which I did a little bit of research on, and I'm not overly au fait on the science with it. So you're probably the better person to ask. What's the deal with that?
So you are au fait with the science on stem cell injections, because there is none.
Okay,
it's something that came into popularity about 7 or 8 years ago. I hadn't heard about it until I came back from my overseas training fellowships, and there were some people talking about it and doing it. So I looked into it quite a bit, because I thought, maybe this is something I should be offering people. And I don't know if you know the way it works. The way it works is that you get a liposuction done on your tummy, and they take a bit of your belly fat and they spin it around in a centrifuge, and they take some cells off the top of it, call them stem cells, and inject them into your joint. Right. The science for that doesn't work for me. I won't go into the details of it, but needless to say, people might remember that there was a whole lot of controversy in the media 10 or 15 years ago about using fetal stem cells for research. If you could get stem cells out of your belly fat, we wouldn't have had to have that argument. Fetal stem cells for research. So I'm not convinced that what they inject into your knee is stem cells. There's no evidence that injecting stem cells into your knee or hip will make your cartilage grow back, which is what the claim is. That's what the treatment's supposed to be. So osteoarthritis is loss of cartilage, and you're meant to inject these cells in, they turn into cartilage cells, and your cartilage grows back. There's no evidence to support that. A number of the professional associations in Australia have come out and said that no one should be doing this outside of a research trial. And I don't think it'll ever be shown to work, because I know that I can take someone's own cartilage cells from their own cartilage, send them to a lab, grow those cartilage cells up so that we've got multiple of their own cartilage cells, put them back into a defect in their knee, and use some techniques to secure those cartilage cells back in that spot, and they won't grow new cartilage and heal a cartilage defect. So I don't know if your cartilage cells won't work to do that. I don't understand why belly fat cells would. There's no science on it, but the basic premise of it just doesn't add up at all. And it shouldn't be done outside of a research project. And it's horrendously expensive. People charge $10,000 or $12,000 to do it.
There are some other injections that sort of buzzwords around the place. Do you want to talk a bit more about some of the other types of injections that you know of?
Yeah, so the three other popular groups of injections are platelet-rich plasma, sort of
PRP, right?
Yeah, PRP, lubricant-type injections. So Synvisc and Durolane are the two brand names of those, and steroid injections. I'll start with the PRP, the platelet-rich plasma. There's no evidence that it works, and there's a bit of evidence that it doesn't work. There's a big medical research group called the Cochrane Collaboration, which do big research projects. They look through all the evidence and reanalyze the numbers and provide summaries, and it's one of the most respected resources for doctors in the world. I believe they're doing another look into platelet-rich plasma at the moment. They tried to do it about 10 years ago, but they aborted their project because they couldn't identify one single research study that they felt was good enough quality to review, to look at. And PRP's been around for quite a long time now. So people have been looking at it for a long time. So if there was quality research that showed it worked, that would have come to light by now, but it hasn't. And it's also moderately expensive, and yeah, almost certainly doesn't work. The other one, the Durolane Synvisc, they also have good evidence that shows that they're no better than injecting water into the knee. So we know that they effectively don't work, and they carry risks. You can get quite significant inflammatory reaction, and it can actually make your knee a lot worse. If you have those, you can react to the substance. As I said, it's no better than injecting water. The longest one, the one we've known about for the longest, been using for the longest, and is probably still the most commonly used, is corticosteroid injections. And these are still used very commonly to treat lots of things. I have to stress that I'm talking about hip and knee arthritis now. I don't know the research in other areas, but in hip and knee arthritis, steroid injection has been shown to be no more effective than injecting salty water, saline water into the knee. But it comes at a significant price. There's a significant risk of getting an infection with a steroid injection. So if you have a steroid injection into a joint and then have a hip or knee replacement done within the next 3 months, we know that your risk of infection in your hip and knee replacement is significantly increased. And our evidence now goes out to show that that's actually carries out to 12 months after you've had your last injection, and it may last forever, that effect. So having a steroid injection, and that it's the same for the Synvisc and Durolane as well. So having those injections compromises your ability or the safety of doing a hip or knee replacement for you in future. And that's not even if you necessarily you don't have to have an infection in your joint at the time of the injection. It's just if you've had an injection, then you have that risk. The other risk is that there is a risk of getting an infection in your joint at the time of the injection. And we see around about 20 people a year at the John Hunter who come in with infected knees, who've got that infection because they've had an injection in their knee. Despite this, it's still commonly used, even by some of my colleagues. In fact, there's an orthopedic surgeon colleague of mine who has quite bad knee arthritis, he's not a knee surgeon, but in all our meetings for a number of years, he's been saying we're wrong to say that injections don't work because he gets them and he feels they make him better. And we've been saying, look, you're at risk. You're eventually getting a knee replacement. You're making your risk higher. He's actually being treated at the moment for a really bad infection in his knee. So he's had to have surgery for an infected knee. And if you then do a knee replacement after someone's had an infection in the knee, that's a huge problem. The chance of that knee replacement failing in the first couple of years is about a quarter, which is 5 times higher than I'd expect the failure rate at 10 years to be.
Yeah, wow, that's quite significant, especially for a treatment modality that's very, very common, and something I wasn't overly aware of up until maybe about 12 months ago, 2 years ago, kind of thing as well. So I think that's a big take home for me, and probably a lot of the patients potentially listening as well.
Yeah, it's always good to sort of clear the air on a few of those things, because I think, some patients who develop this program, this sort of problem or arthritis in the hip or the knee, they go to Dr. Google and they find out all these buzzwords. They don't quite understand what they mean or what the evidence is behind them.
And I put the injections in a different category to some of the other things we were talking about. So if you're taking glucosamine, probably not going to do you any harm. If you're taking Panadol, it's not going to do you any harm. So I tell people, yeah, keep going. But injections are more dangerous than they are helpful. So I never do them anymore. And I very strongly discourage patients from having other people do it.
Yeah, perfect. It sounds really good.
Yeah, cool. We might wrap episode 1 up here with you, Stuart. Is there any sort of final thoughts, Duncan?
No, I think couple of takeaways for me were definitely around that cortisone injection that we talked about, the glucosamine and things. That conversation will definitely help me have those conversations with patients more confidently as well. Anything for you?
Yeah, well, everything was obviously really helpful, and I think for patients listening to this who are going through that process and starting to learn about their pain and about the problem that they might be having in the hip or the knee, any kind of information is helpful, and particularly when it comes from verified sources like yourself. So really appreciate you jumping on the podcast.
I think the big things to take away are hip and knee replacement are excellent operations if you need them, but try other things first. So you should have tried non-operative treatments first, but focus on ones that work, like physio, losing weight, keeping active, and non-steroidal anti-inflammatories rather than the other ones.
Yeah, for sure. I think we'll do another podcast in the future around the GLAD trials, which is something that happened a while ago, but how physio and weight loss can help. That'll be in a future episode. Well, thanks for joining us today, Stuart, and we will have you back on. We're doing a little series with Stuart at the moment, so keep listening over the next couple of weeks, and you'll hear some other really cool subjects that we're going to talk about.
Thanks very much. My pleasure.